Fine. Can you hear us?
Yes. Andre, we have you on the screen.
Yeah, wonderful. Yeah, perfect. I'm with Sven. So this is not the foot loop case, which will come later, the complex case, which Mansi will do here for us. This is here now. Also retrograde case, below the knee, actually completely below the knee, total occlusion, and maybe Sven, you can introduce the case.
Yeah, thank you, Andre. Good afternoon to New York. And can I please have the first patient slide? The first one, please. So this is a patient, actually. Can you display the first slide? The first. Go back, yeah, okay. This is a patient, yeah, with a CLI, 27-year-old gentleman who presents with rest pain of the right foot. He has also severe claudication with a short walking capacity. ABI at the right foot is 0.32. And he had already some work on this limb with a PTA of the distal SFA in May of this year, and failure attempt to open up a occlusion of the tibio-peroneal trunk. Furthermore, he has chronic renal insufficiency. Next slide. And he has arterial hypertension, hyperlipidemia. He's a former smoker and has diabetes mellitus. Next slide. This is the angiography. You can see there's actually an occlusion of the distal popliteal artery as well as the tibio-peroneal trunk. And the peroneal artery is the only artery that's going down to the foot and providing the blood supply for the foot arteries. And next slide, our strategy here. We are in with the right undergrade access with a 5 French sheaths and 6 French sheaths, undergrade sheaths. And after failed attempt to recanalize in an undergrade fashion of the tibio-peroneal trunk, we are also ready to do the retrograde access via the peroneal artery. And then we do PTA here, and we also plan the application or the intraarterial wall injection of dexamethasone with the bullfrog device.
Yeah, I think the next slide shows you the bullfrog device. Please switch to the next slide. For those who do not know the device, can you? Yeah, here. So hopefully the animations will work. So it's as you can see, it's a little balloon, looks like a bullfrog. And when you inflate the balloon, a little needle will come out of the balloon and will be pressed into the arterial wall. And then you can inject actually whatever you want. Currently, the studies are ongoing with dexamethasone, so we inject dexamethasone into the perivascular surrounding to stop the restenosis cascade in a very early phase. I think it's a very interesting device, which we want to, once we are done here with passing and pre-dilatation, use here in this case. But now we can switch here to the angio, and Marco also joined us here for this case. You can see here, so as you heard, some treatment was done on the SFA and distal and popliteal artery, but this is the remaining occlusion, which was not passed here from antegrade. Well, we take now the occasion here to do this in a retrograde way. Patient is feeling already better, but I think to assist here really what has been done to the SFA and popliteal artery, we think we clearly need to open up here now. This segment you can see here, the peroneal artery going down. So it's in fact, here, distal, a distal popliteal occlusion. And I think a very nice case to approach from retrograde. Of course, you can try to puncture here, well, what's left here from the dorsalis pedis, but clearly we would puncture here now the peroneal artery. That's what we want to show. And we want to take here a pedal sheath in. Usually we do peroneal access without sheath, just support catheter, but this artery is also very strong, and in fact, we have never seen any problems with a sheath, pedal sheath from retrograde, neither in dorsalis pedis or posterior, whatever. So I think it's also a safe way to access the artery here in the peroneal artery. Not sure where you can really see this very well on the camera. You can see that the right leg, we have the C-arm right oblique. And what I want to show you, which is a little bit different here in this case than to other cases, of course, we have to choose here an angulation where the bones between, where the bones give us some space, because we have to, when we puncture from anterior into the peroneal artery, go through the membrane between the bones. And you can see here also in a quite right oblique view, the bones are relatively close to each other. But more important is if I inject here contrast to see that not only the space between the bones is big, but the artery is really between the bones. And I think this is here now a perfect angulation here to get the needle through the two bones into the artery. Yeah, I gave already some local anesthesia. It's a 7 centimeter long 21 gauge needle. A pedal puncture set actually comes with a 4 centimeter long one, which I think is too small, too short here for this access, because the artery is relatively deep here in the calf. And of course now I will magnify a little bit, and Svenny will tell me when blood will come out of the needle here. So I inject contrast while I also go down here. I'm not sure whether this is a good direction. The needle really should be on top of the artery, and during the puncturing I should not really try to take the artery to another course. Yeah, I've pulled it a little back and now I go here. Is there something? No.
No.
Just a moment. No?
No.
Oh, it's relatively deep, huh?
Oh. Yeah.
Okay, I didn't inject anymore, but I felt the calcium of the artery. And either you switch, I'm not sure whether you can see the blood coming out of the needle, probably not. Either you switch to another oblique view here to see how, first of all, where the needle tip actually opens to. I think this is also important, that the needle tip opens to the head, so to say. And then in this other angulation, in a controlled way, you take here the wire in. And this is, for this access, usually an 018 wire. Marco, something different? Would you do something different? Yeah. Okay.
So you're using the 018 wire to have more support for inserting a small sheath or support catheters, right?
Yeah, exactly. So because the artery is relatively deep in the calf, and as I said, we need a 4 centimeter long needle here to reach actually to the artery from the skin. So in that depth, I think it's better to have a stiffer, more supportive wire indeed, yeah. So now the sheath is in. I take the dilator out, and there is also already some back bleeding here. And now, we take the valve on it.
So Andre, when are you using a sheath for retrograde tibial access, and when are you avoid the sheath and just go with the support catheter? What's the advantage of a micro sheath?
Yeah, the advantage of micro sheaths are relatively clear. You can really nicely change from support catheter to balloon and vice versa very easily. And really, in difficult lesions, that is a clear advantage when you want to do something like double balloon technique within the occlusion, if you need this here, for example. So therefore, actually, let's say in more complex lesion, clearly, I start directly with a sheath. In other lesions, you may also start with a support catheter only in M16I. Yeah. But over the time and experience, we also checked our cases during follow-up. where we inserted this 2.9 French sheath. And we had an eye on whether we would damage here the artery over time, induce a restenosis or something. But we haven't seen anything as we haven't seen with the sheathless approach. So at the end, yeah, we are more confident, and it becomes a little bit more our standard technique here than in the past to go directly with a sheath in. Okay, you see here now, this is here a CXI catheter. Through that CXI catheter, I can exchange from an 014 wire to an 018 wire, whatever. Give a roadmap here from RETROGRADE, and I think we are on a good way. Maybe, Marco, what do you think? You want to push the wire here a little bit in? Or?
I think you are in a good position.
Yeah. I hold the catheter, and you push the wire a little bit, because this CXI is a little bit slippery, so I need to hold it. Yeah, please, yeah. Let's take it in. Yeah, good way. I follow you. Oops, sorry. Yeah. We can, I think, also create a loop if you want and push it. Yeah, sorry. You want to loop or, perfect, yeah. Yeah. Marco, what do you think? Would you first take the wire as straight or directly loop it here?
We have very few resistance.
Okay.
It's quite soft.
So, okay, I follow a little bit. And, okay, perfect.
Yeah.
Wonderful.
Very soft, actually.
Yeah, nice. Nochmal for 18. Yeah, so now we take a Judkins right catheter here into the sheath from RETROGRADE to snare out the wire. Sven, wenn du da den Katheter hier halten könntest. And from this side, we probably, it's better here to take a new wire, because this is relatively destroyed at the tip. Was not completely soft, wasn't it? I mean,
can repair.
Yeah, I mean, according to the wire tip, which is left, I think, was also a little calcific, this lesion, maybe. Okay, so Sven is taking the catheter a little further down. We may need here a torquer to do this. Just a moment. And
yeah,
so Sven is directing the catheter to the arterial wall. Maybe to the other wall, or this one. Just a moment. Can you take it to the other one? Or stay here? Yeah, just a moment.
It's moving.
I'm touching here the tip, so I'm pulling back my wire for 0.5 millimeter and giving a torque, and then it flips here into the catheter. I push also the CXI catheter here now in the Judkins to have more support and stability, and now we push it out and we can take a balloon down here from the sheath. Yeah.
So that was already very nicely done, Andre, the crossing and so on. So I understood your eventual strategy is here to use this micro-infusion system. Prior to that, you're going to just balloon the vessel, or are you planning anything else?
Actually, yeah. First, we try to balloon this vessel only without stents. I think this is not really a good lesion or area for stenting. Of course, I mean, if it would be short, no problem with a drug-eluting balloon implant, the stent, or a supera, more proximal. But here, I mean, the lesion is, has a bigger diameter proximal and small distal. So therefore, difficult to find a good stenting solution. Drug-coated balloons, maybe, yeah, for below the knee, not so much information. So therefore, our hope is that maybe this kind of device will help us here to have better patency in this area.
We are here having a little problem that we have still one more talk to do. I mean, would it be possible that we put you just on the side screen now for the balloon dilatation so that we have enough time to see the bullfrog procedure?
Yes.
Okay.
Good idea.
Okay, so let's do that. I would then ask George Adams.
Again.
So maybe we can just go back because that's more or less identical technique which we have just seen. So, Andre, we are back with you.
Yeah, perfect. So just a moment, just creating here some kind of roadmap. So currently now we have the device already in. That's why we do not really see here flow. There's also a little bit of dissection. We also have already taken the sheath out of the peroneal, and we have a blood pressure cuff around. So there cannot be really a very good flow here. Here is after ballooning our artery. So we have some spasm here at the pedal sheath, so that's not a problem. We do have some dissection indeed here at the distal peroneal. And nevertheless, we thought to now first start with the bullfrog device to get the dexamethasone into the arterial wall. Later on, we have to decide once again whether we have to stabilize with a stent. But I think this sequence is better. First, take the drug into the arterial wall and then think of maybe stenting that area. So therefore, you can see here, we want to start here. This is a small device. It's a 2-millimeter device, a device which is possible to use here in arteries of diameter 2 to 4. 2 more others for bigger arteries. And you can see here now, if I enlarge here now, I'll take the bone a little bit away. Maybe, yeah, that's better. So you can see here now, this is the newer version. It's an over-the-wire version. With this, you can also twist. You can see here now 3 markers. Distal and proximal is the end of the balloon, and in the middle, this is the indicating where the needle will go out. And when I inflate here now the balloon with not more than 2 atmospheres, there's a valve to open. So you can see here now the 2 markers in the middle portion, they separate from each other. And now the needle should be in the arterial wall. The first injection is, we take something like 0.5 milliliter in. We do it with DSA. Sometimes the needle doesn't really go into the arterial wall because we hit maybe an area where the arterial wall is too calcified, as here. You can see here that now the dexamethasone, which is mixed a little bit with contrast, does not go into the arterial wall, into the surrounding tissue, but goes downwards. So that means this needle obviously just now did not hit or go through. So I twist now the device. You can see here, this is what is new with this device. I can take it to the other side and try here once again to take the needle in. And with DSA, it's just easier to see whether, this is what I want to see. That's how it should look like. It doesn't look very nice if you're not familiar with this, but it's clearly not a perforation. This is really the surrounding tissue of the artery. You can see how it nicely spreads, not only proximal and distal, but also around the artery. So therefore, you do not necessarily have to do the puncturing in every direction, but you do it at one spot, and then you go back here 2.5 centimeters, and find another place where to inflate the balloon once again, and continue with the procedure. Yeah.
So I'm sure for somebody who sees that for the first time, it's a bit scary to see. I mean, we must say that in our experience, it has always proven to be a very safe technique. I don't know if somebody wants to share his experience from the panel. I mean, George,
I mean, I think it's pretty safe. I've never had any perforation or significant even fistula from it.
How about compression of the lumen from that little bubble of fluid you put around? Ever seen anything like that?
I haven't seen any compression of the lumen. You know, such a small needle. I mean, you're talking about the blood flow that goes into the adventitia, or the dexamethasone and dye that go into the adventitia. I've never had any compression.
So do you think that dexamethasone is the right drug? So you can use this balloon for anything you want. Is that going to be the right drug?
Well, I mean, it's currently, let's say, the first study which was ongoing, as you know, in the superficial femoral artery dance study, and then we have two projects, randomized projects in the below the knee arteries, one in the US and one in Europe. But you're right. I mean, this is one approach to interact very early with the restenosis cascade on the inflammation level. Is an interesting study just started now with using a sirolimus steroid. It's kind of a dose-finding study, which is actually ongoing here in the United States with 60 patients. To deliver sirolimus actually into the adventitia, which with like classic drug-coated balloon has been very difficult.
It's too small.
So I think it's interesting. And in theory, going further, I mean, you may even be able to use drug combinations. So I think it's really a method of delivering drug what we are showing here, and that's why we find that also very appealing.
So I had experience with the rapid exchange, but not this OTW. It looks fairly thick at the proximal. What's the French size of the proximal part of the over the wire?
Andre, can you take this question? What's the French size of the new over the wire system? Did it change to the rapid exchange?
No, it didn't change. It didn't get bigger. So again, it's 6 French here for below the knee, and you need 7 French for the bigger balloons. You have seen now some successful injections, and then we went into the P3 segment, and there our device seems to be too small now, and therefore we upsize now to the next one, which we can use for diameters of 3 to 6 millimeters.
So that's also the reason why you mix the drug with contrast, because if you don't reach the wall and you inject the fluid not into the vessel wall but rather into the lumen, then you, with the contrast, you immediately realize that. So it's kind of a quality control for reaching the adventitia.
Okay. You have wire? The old wire? Okay.
Yeah, exactly. Here, for example, it was partially going outside, but partially obviously also into the artery, and the next one was then clearly going into the artery. Ja. Geht es da rein? Ja, überhaupt.
Geht rein.
Achtung, da. Ja, sorry.
Passt du auf den Draht noch?
Ja.
Andre,
yeah.
This is
Steven. Yes, hi.
That you actually can personalize care. You know, we talk about different agents, but, you know, we talked about paclitaxel, sirolimus, your anti-neoproliferatives, stem cells, anti-inflammatories. This device, you could deliver almost any drug, depending on what type of patient you have. So it really opens up a whole new area of medicine.
Yeah.
Andre, this is Steven. I just wanted to ask you, what was the size of the pre-dilatation balloon? And is your impression if you use a smaller pre-dilatation balloon, do you get better penetration of the needle into the artery?
That's a good point. So we used a 3 millimeter in the trunk and a 4 millimeter in the popliteal artery. So it was not oversized, but you're right. Maybe if you're not too aggressive, it may be a little bit more successful. So far, this is not this strategy, but future we may try this approach. Yeah, correct. Okay, so that's.
So just for the audience,
this is the bigger device?
I want to make you aware we are already a little bit into the lunch break. I think we are staying here in Leipzig probably for a few more minutes to see the end of this procedures, but if anybody feels hungry, I mean, feel free to go on, and in any case, we reconvene here 20 minutes past 1 o'clock for the next live case, actually, from Mount Sinai.
Yeah. Yeah, sorry, preparation takes a little bit of a time.
No problem.
Okay. Now we connect here DEXA.
So how many more injections do you think you have to do in the popliteal?
3, I would say. Okay, please inflate. So this is now the bigger one. Up to 2 atmospheres, there's a valve, so you cannot overstretch this balloon. And now I try to take the drug in. That was maybe not enough. Can you take the pressure down once again? Yeah, not enough contrast here in the solution. Let me change once again, sorry. Let's take it a little higher. Yeah, let's do it here once again, please. Okay, this is again a successful one. And I guess you can nicely see how it spreads proximal and distal, balloon down. We may, here there is maybe a gap. This is actually, I think the origin of the antertibial artery. So I try again to take the needle to the other side. And this is clearly something new compared to the monorail device, the older one. Yeah. Please inflate now.
So
and it really works, yeah.
Seems to be a much better torque transition. Maybe just to the point that you had to upsize the device. That's rather unusual in our experience. So typically you get along with one balloon because it's, it covers a relatively large diameter range. But clearly if you start in the small tibial vessel and then you go into a relatively big popliteal artery, then you encounter the situation that you need actually 2 devices.
Yeah, that was not so successful. We can partially, we can try to bring the needle once again into the other direction. Severe calcification can sometimes be a problem for the needle to penetrate. Just a moment. Please inflate.
So Dirk, when you use this strategy, are you undersizing the balloon?
I think this is the last one I'm going to do.
First with your angioplasty and then delivering drug, and that's you're trying to stop at a 1-to-1 angioplasty followed by drug delivery? What's the strategy?
Well, actually we go for 1-to-1 dilatation, and then we perform the drug delivery, and typically after that we are done. So we always check. I mean, there's a concern, of course, that if you inject something into the wall, that you may somehow interfere with your vessel lumen, but as a matter of fact, you're injecting into the adventitia, so there's a lot of space for the fluid to go. So we typically see the lumen is as perfect as it was before the treatment, after the bullfrog. So.
And you accept the 20% residual like you would with the DCB since you're given antiproliferative therapy?
Yeah, I mean, you're free to do what you want to do. I mean, and we of course try to stay away from stenting in the tibials and in the popliteal arteries. But theoretically, you could also place a stent then after. I mean, if needed, if a bailout stent becomes necessary, or you could upsize balloon after the treatment. So I think it's. I mean, in the protocols for the trials, of course, there's a clear bailout stent criteria, which with an intention to minimize this.
Inside?
Yeah, it could also go to the thrombus.
So it's going to be interesting to see here the angiogram after the treatment.
Yeah, my Druck runter. The last injections were, let's say, partially effective, maybe due to calcification. Now we take the blood pressure down. Yeah, I'm not sure about the result. I'm afraid that we also had maybe a little bit of thrombus in that lesion. Let's see. Nochmal Nitro.
Nitro, brauchen wir nochmal?
Okay. So I wait until the pressure is completely down of the blood pressure cuff, and now I'll give you an injection. Hopefully we have some flow. Yeah, flow. But
A little
Not
bit
sure
more work
whether
to
this
do.
can be left without a stent. A little bit of more work to do, exactly.
Okay.
So at the end, maybe indeed we need a stent here. Yeah.
Yeah, I mean, this is the area which looked awkward from the beginning after the crossing. I mean, that's...
Yeah.
Okay, Andre, I think for now I would say we leave you and take your time to finish the case. I think we've seen a very elegant and quick puncture, a very effective retrograde crossing, and interesting new technology for drug delivery. And I'm sure you will finish the rest of the case as well. I think Phil told me we will have the images on the screen. Yeah, so we can watch it also in the exhibition, and maybe you can show us the final result when we come back for the next afternoon case. Thank you very much, Andre.
Okay.